Good morning, everyone. I would like to welcome you all for today's clinical meeting. We'll start off with our first case, an inverted paradox by Dr. John Kurian from Medicine 4.
So good morning, everyone. Today I'm presenting my clinical meeting. The topic is the inverted paradox. So let's start directly into the clinical scenario. 31-year-old gentleman, Mr. X, presented with weakness and numbness over the right side of the body for one day. It was sudden in onset. There was also slurring of speech with a deviation of angle of mouth to left side. And there was no history of seizure, no signs of cortical involvement, no involvement of bowel and bladder. So coming to Comos, he had CVA in past in 2021. At that time, he had a cruciate hemiparesis that is ignored left lower limb and right upper limb. And he had a CV on 2022 also with September. At that time, he had weakness in the right upper limb and right lower limb, which resolved within 5 days. Coming to the personal history, is occasional alcoholic. He drinks about 3 units of alcohol per month, and he is a reformed smoker. He is married with no children. Family history, there is no history of CV in family. So before coming to the examination part, I just want to put an X-ray of this patient. So can anyone identify the 3 abnormalities in the X-ray and name the condition? So I'll just tell you. So it's dextrocardia along with the situs node, because we can see the stomach bubble on the right side, and you can see, if we look closely, we can see some signs of bronchitis also. So he's already a diagnosed case of cartilaginous syndrome with situs inversus totalis, along with chronic bronchitis, and he has chronic sinusitis also. Along with that, coming to the examination part. On examination on vitals, vitals were 120/60 on arrival with pulse rate of 100 per minute, and respiratory rate it was 26 per minute. And general physical examination, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or any sinus tenderness. Systemic examination wise, CNS, higher mental function. He is a right-handed person, is oriented to time, place, and person, and his memory are intact. Cranial nerve examination, there was decreased sensation in the right side of the face compared to left side, but corner reflex was present, and he had a right human facial palsy also. And gag was absent on the right side. And sensory examination, both large fibers and small fibers excision were absent in the right side. And motor system examination, power was 0/5 in the right upper limb and 1/5 in the right lower limb, but the left side was normal. So reflexes were exaggerated on the right side and plantar upgoing on right side. Cerebellar signs were negative. Cardiovascular examination, and there is no signs of meningitis, spinal tenderness. Cardiovascular system examination, apex beat not felt in the left side, apex beat was felt in the right side, in the fifth intercostal space in the mid-clavicular line. There was no murmurs. Respiratory system examination, the bilateral air entry were normal, but coarse crepitations were there on both sides. And on the inframammary region, and paraudon examination were within normal limit. So clinical diagnosis: acute onset of focal neurological deficit, right hemiplegia with right human facial palsy, anatomical.
No, there is more deficits.
Yeah, right.
Hemiplegia, human facial palsy. You might take this. You describe a lot of other things. Sensations.
The sensation,
sensory
also there, sir. Right hemiplegia with It has he has got a right hemiplegia with hemi anesthesia, along with he has a right human facial palsy also was there, and was also there, and his weakness was acute in onset, and he had a similar weakness on the right side, just 1 year back, and just resolved spontaneously. So we did a CT initially. At that time itself, the patient has developed a acute ulcerative infarct on the left capsular ganglionic region with in the MCA perfected region, and all prothrombotic workup since it was a young male with recurrent CVR, and all prothrombotic workup which was all came negative, and the ECG just showed no arrhythmia, and echo showed no clots. We had a trans-esophageal echo because of the recurrent CVA, which has revealed a patent foramen oval with a defect size of 1 millimeters, and the length of tunnel was 14 millimeters with the IAS aneurysm. It was IAS aneurysm was absent, and we had done a bubble contrast study also to confirm it, and which showed a right to left shunt which is present in normal breathing, and there is an increase in shunt during Valsalva maneuver. Upla workup, BBUS and homocysteine all came negative for this patient. So cardioembolic stroke.
Right to left shunt.
Right left shunt. Bubble.
How's that possible?
So PFO.
PFO
usually the shunt.
The shunt will always
within the left to right will be the usual shunt pattern, but
because of the
before the so cardioembolic secondary to PFO. So CVA caused by breath. So before beginning my presentation, I just want to give an overall view what was begun. So scoring for PFO causing paradoxical embolism and high risk PFO, which we have to detect, and management of these conditions. So these are the scoring system which we use for the paradoxical embolism, paradoxical embolism in PFO. So if the score according to score, we have to put all the history and give a score to all these particular things. And if you get a score of more than 5, we can 5 to 6. We can say that it will cause 62 more than 62% of the time. This stroke will be caused by PFO. And there is a Pascal classification which quantify with a lot of other features without PFO. If the PFO is having a standing embothrombus and the ROP score is around between 0 to 6, so definitely the chance of it will be definitely because that the starting thrombus is there. So this thrombus can definitely cause a embolism. And in case of other features including the PFO size and PFO length, and along with if you compare with the ROP score, we can probably tell that whether this PFO has caused the stroke in these patients. This is where this scoring system comes in. So this is a study which happened in CMC, where in studies, other than doing rather than directly going for a trans-esophageal echo, they have done a transcranial Doppler with bubble contrast study, which is used as an invasive test in the bedside for screening of PFO or any other shunts which happen right to left shunt, which can probably cause a emboli. So what they have done is they have taken all the young stock, and after ruling out all the possible all the prothrombotic workup, they have done a transcranial Doppler with contrast bubble study was done, and of them which came positive for the study, 72 people came positive for the study. Of them, when they did the esophageal echo, 65 people of them had a patent foramen oval, and 4 people already have another artery to venous connection was also there. Abnormal connection was also there. So my take home from this thing. So rather than going up for if you find a patient, we are suspecting an embolic stroke, probably cardiac, rather than going for a transesophageal directly, we can use a simple screening bedside screening test, which is not invasive as compared to transesophageal echo in the bedside. And if it comes positive, the chance of patient having a patent foramen oval causing an emboli is very high. So this test can be replaced in as a screening test for the esophageal echo. But so this study was happened in CMC, though I put this article. So identification of high risk patent foramen oval.
What about the transthoracic echo?
Transthoracic
it's a transesophageal was the reference and
transthoracic
doing a simple
so usually small foramen. Even our patient itself, we done an echo initially. bubble. We done an initial echo for our patient also. At that time there was no foramen oval, so the rate of detection of a small patent foramen oval in a normal routine echo is very difficult. So anyway, that our patient itself, we got it to a transesophageal echo. So, identification of high-risk patent foramen oval associated with cryptogenic stroke and development of a scoring. So, it's a Nakayama scoring system where they have quantified the foramen oval, high-risk foramen oval. So, according to their classification, so if a patent foramen oval of size of more than 2 millimeters in height and tunnel length of more than 10 millimeters, and there is an atrial septal defect with aneurysm and hypermobile in the atrial septum and prominent eustachian valve or Chiari network, and the large right to left shunt on at rest or during Valsalva maneuver. So all these criteria, and there is a low angle of PFO between the inferior vena cava. So all these criteria, if you look in a PFO, if this criteria, at least if two are positive, two or more than is positive, we can definitely say that it's a high risk PFO. Therefore, in our case, our patient had a length of tunnel of 14 millimeters and IVC to PFO angle is less than 10 degree. So two criteria are only fulfilled by Nakayama. So its score will comes around 2. So 2 or more than is an indication for doing a PFO closure for patients. If the patient, especially our patient, he is having the third CVA for the last 3 years. So we have advised previously itself, we have advised the patient for a PFO closure. He has postponed the PFO closure. So now again he landed up with the CVA. So this kind of patients is an ideal candidate for a PFO closure, early PFO closure to prevent further mortality and morbidity. So there's a study, we have defense PFO trial. So this study which they have done is actually they have selected patients with the patent foramen oval causing who had a CVS. So at that time they had divided the people into two sections, PFO, where they have one section has identified given PFO closure, other were managed with the medical management with anticoagulation. So after PFO closure, the relative risk for another recurrent ischemic stroke followed up to 2 years was almost nil, and the patient who were continued on medical management had recurrent strokes within these 2 years. Okay, so these all trials are all favoring for if the patient is having a higher risk PFO and causing a recurrent CVA. So all the trials, even there is other closure trial which has already done, showed a similar output, that is early closure will prevent further morbidities in such kind of patients. So by concluding my presentation that, so if a young patient who are suspecting cardiomyopathic CVA, we have to do a thorough workup initially to promote all the prothrombotic workup. Then if it's cardiac embolic, we can use transcranial Doppler rather than directly going for a transesophageal echo, which is probably more of a non-invasive test as a screening method. So after proving that there is a CVA which is caused by cardiac, we can further proceed with transesophageal echo and quantify the PFO. Once we can quantify the PFO, according to risk scale, if we are able to categorize, if it's a high risk PFO, we have to do an early closure to prevent further mortality. So learning points is embolic stroke in PFO, identification of high risk PFO, and defense style PFO closure against medical therapy. Thank you.
Thanks, Dr. John. Is there any questions?
What was the rate of recurrent strokes in the medical management arm of that trial?
We have 70 people were there in 60 people were there in the both study arm as well as in the control arm. On the study, whether the study was done, that is the medical closure was done, the recurrence was almost or zero, and the study arm had 2-3 people have a recurrent strokes again, and but study arm had another side effects of another bleeding manifestation history also was there, because he wasn't. on anticoagulant, which is the dual antiplatelet therapy. Our patient actually, we started on anticoagulation with antiplatelet, but he has missed his medicines for 2-3 days and he has consumed alcohol. So at the time his PTNM became subtherapeutic and again landed up with a CVA, recurrent CVA.
That's my question. So did he get a CVA because his INR was subtherapeutically low or because his PFO was high?
Both are factors, sir. Because when he was in initial closure studies showed there is no significant difference between the medical arm and the medical and the therapeutic and the closure arm. But after the recent studies have proven that closure studies are far more superior to any medical therapy. And
these are the cost of this procedure in CMC.
I'm also not sure, sir.
Because that is probably the reason why the patient didn't get it done last time. Please find that.
I asked ma'am to.
And one more thing, like sir was telling, you said some features about trigeminal nerve. So all that should come in the final diagnosis also, because you are saying it's a cardioembolic stroke, it's multiple infarct probably.
Oh.
So the brainstem is also involved.
Sure.